Hello, everyone. My name is Elpida Argenziano. I'm an LBBC Young Advocate and someone living with oligometastatic breast cancer for almost 6 years. I'm so excited to be having this conversation today, and I'm honored to be joined by Dr. Debu Tripathy, a professor of medicine and chair of the Department of Breast Medical Oncology at the University of Texas MD Anderson Cancer Center, and Dr. Stephen Chmura, who served as the Director of Clinical and Translational Research for Radiation Oncology at the University of Chicago for over a decade, and who's now the Scientific Director of the Cancer Clinical Trials Office at the University of Chicago Comprehensive Cancer Center. You can read more about Dr. Tripathy and Dr. Chmura at lbbc.org. Thank you so much both for joining us. Many people and even doctors are not familiar with the term oligometastatic breast cancer. It's a bit of a mouthful, and at times in this discussion, we may refer to it as oligomets or OMBC, just for purposes of brevity. Oligometastatic breast cancer is categorized by a single or a few detectable metastatic lesions at the time of diagnosis. People with oligomets may have improved outcomes and may even have their doctors describe their treatment as curative. In this interview, Dr. Tripathy and Dr. Chmura will explain this relatively rare presentation of MBC. We'll talk about treatment approaches, and we'll share a look into some of the research. Let's start off with you, Dr. Tripathy. Can we have you describe a little bit about your institution's working definition of oligometastatic breast cancer?
Oligometastatic breast cancer, by definition, means one or a few sites. And the definition of how many sites that would be varies depending on the study that is being done. At our institution, we typically define it as 2 to 3 lesions. Lesions can be different in size and distribution, so we don't like to put a very hard definition on it. But of course, for clinical trials, you need to, because you need to define your population. And Steve Chmura will talk a little bit more about the national randomized study that's ongoing and its definitions. But at our institution, 2 to 3 is the general definition. Part of it also depends on, as I mentioned, how easy or approachable it will be to local treatment, which we will get into later.
Thank you. Dr. Chmura, how is that similar to how you would define it at University of Chicago, or is there any difference there?
Yes, I think it is quite similar. I think that we use the national trial definitions, which is going to be 1 to 4 metastases, and no metastases can be larger than about 5 centimeters in size. And that's more for the practical limitations of doing, say, the highly focused radiation therapy.
That's so interesting, because I've read a lot of research, and I've often heard less than 5 metastases. And I've never actually heard the 5 to 7 centimeters in size as another criteria. So that's very interesting. That's the first time I've heard that. I've also heard of, I can't remember which trial, but I'd heard of one where they were looking at up to 10 metastases to see if we could sort of push the envelope of that.
Yeah. So I think in general, while everyone in the prior trials, and keep in mind the prior trials are really a collection of prospectively treated patients from single institutions, while most of them said that they would allow up to, say, 5 metastases on treatment. In reality, most patients only had 1, maybe 2. And that was the whole rationale why the NCI and Energy Oncology ran Energy BR001. It was to say, well, how could we safely do quality and define somebody who then even had 3 to 4? So then that trial is completed. It allowed the second study, the randomized study, to expand from being only 1 to 2 up to 3 to 4. So I think it is easy to say treat 5, but because of the difficulty in terms of the software and the hardware and focusing the beams and being sure that the beams do not overlap, right? It gets hard. It gets exponentially harder as you try to treat more things using this type of high dose focused radiation.
Interesting.
One thing that I would also add is the size really depends on whether it can be treated curatively. In the particular trial that Steve is mentioning, stereotactic body radiation is used, but part of the reason we have been motivated to treat oligometastatic disease in the first place is that historical series that are maybe one or two or a very few number of patients have suggested that the initial treatment that was used many years ago for oligometastatic disease was surgery, because that's all we had. We didn't really have focused radiation and radio frequency ablation and things of that nature. So we've extended that concept, knowing that some patients can live the rest of their lives without recurring after the excision of a solitary metastasis, for example, in the lung or in the liver. That's where our initial experience came from. We've been developing new technologies very rapidly, faster than our ability to study the long-term effects of treating these oligometastatic lesions with less invasive therapies that are very effective, such as stereotactic body radiation, which of course is the foundation of the randomized trial. But other technologies can be used as well. And that's why the definition really varies on what's feasible, what can be approached locally in a safe manner and an effective manner. As tumors get bigger and more irregularly shaped, it may be more difficult to treat them with a single modality, a local modality. That
makes sense. Just to clarify, you said zero, when we're talking about the number of metastases, it is across it could be across multiple organs. Is that correct? So across,
exactly,
let's say, bones and lung. I think there's also been some question around how do you count nodes that are not just regular lymph nodes? Can you talk a little bit about, I guess, Dr. Tripathy, if we could hear from you first, how do you count things like skin mets? Could you count someone who has a couple of skin mets as oligo, and or someone who has some node mets? How would you categorize them, if so?
Yes, a nodal met is a site, especially if it's not a regional node. Sometimes regional nodes might be handled locally because they are considered part of early stage breast cancer when in the breast or in the nodes, and sometimes those will be removed surgically. But if someone has metastatic disease, really it's going to be any site, especially lymph nodes that are, for example, in the mediastinum or areas that are not. The mediastinum would be in the chest or other areas outside of the regional area.
Excellent. Great. Thank you. So that helps. So that's sort of sounds like there's some consistency there across both of you for just straight definition. What about your definition of oligoprogression or oligorecurrence? Dr. Chimura, what's your institution's definition?
Yeah. I think that those terms are pretty hard to define. There is a new astro-estro consensus statement, right, attempting to define them. But I think in general, we think of it as a patient, if we think of oligoprogression, as someone who's doing extremely well on systemic therapy. However, maybe one or two areas start to grow after a long period of time. I think it's an easy thing to talk about because all of us can see that happening, right? That the systemic agents, which are fantastic, are working extremely well everywhere, and maybe only one or two clones have evolved and are kind of escaping and are resistant. So, but actually trying to define that and run clinical trials around it, people have been trying to design them for, I think I've heard, probably 30 proposals, and it is quite hard to design trials around these ideas.
And that is that because, and just to back up a minute, so Astro and Estro, can you just clarify what those acronyms?
Yes. Oh, I'm sorry. Astro is the American Society of Radiation Oncology, and Estro is the European society. So in December 2020, there's a sort of joint statement trying to define these terms, right? Oligo progressive, oligo recurrence, and there's an induced oligo, and there's a lot of oligo names in there. But I think that these words are used often, and I think that for the purpose of the ongoing clinical trials, we are really focusing on the de novo presentation of pure oligometastases.
Okay, I see. Thank you. And just so I understand that the reason it's so difficult to define oligoprogression or oligorecurrence, is that because there's so many scenarios that could happen?
Yeah, exactly, right? Yeah,
Okay.
absolutely, right? It's because the fact that is it the same thing if, say, somebody starts out with, say, 20 areas of disease, and now you could only find 2, but that is quite like different from that someone starts out having 20 and 18 stop growing, but yet 2 are growing. Like, this kind of seems like a very different scenario, correct?
I see.
So as you start to evolve, almost no patient is the same, yet everybody keeps using this word. And I think it just sort of means almost like a pop culture word, is like, oh, a few areas are not doing well, and can you go and like spot weld them or something? But it's very hard to define, and I think it's why we don't see any clinical trials really focusing on that, and probably won't ever see them.
Interesting. That's interesting from a patient's perspective, and I might be the only one, but I guess I was thinking of it more in terms of an oligometastatic patient who was de novo, started out as oligometastatic, was treated systemically, and then maybe a couple of mets popped up again.
And that is like another person. Exactly.
Right.
Exactly.
And
and so now you have a third
mets,
person. Right. Yeah. But but there are so many scenarios, and these oligoprogressive terms are just sort of this big umbrella to capture everyone.
Yeah, I want to emphasize how different these cases can be. You are right that commonly we define oligometastatic disease at the first time that we see someone presenting with metastatic cancer, either the first time they're diagnosed and happen to have metastatic cancer, or if they recur later. There are cases, however, where patients have multiple areas that we would not consider metastatic, but they have a wonderful response to their treatment. And a lot of time goes by. So time is a very important predictor of how someone will do. If someone goes a very long time and only has one remaining lesion, sometimes we will go after that, either with radiation or surgery, only because the patient has gone so long and sort of declared themselves as someone whose metastatic cancer is more under control. We don't really know much about how cancer stays under control when initial treatment. Is it that it was so sensitive to the treatment, or is it that some of the body's own mechanisms, such as immune mechanisms, are kicking into a greater extent in one person than they might in another? We still have yet to understand what the underlying biology is as to why people have contained metastatic cancer, but that's really at the heart of the issue, is what can we do to actually help these patients maintain these very long remissions? And is it important to remove whatever burden of cancer you can find that hadn't disappeared on its own with treatment, or for whatever reason only spread to limited areas? And there's so much we have to learn. The only way to do this is to broadly test patients under the best definition we can come under, and then really follow them over time so we can get some better statistics and outcomes in order to better counsel patients, and also so that we can learn more about the biology and the clinical history of these patients by studying them formally in a clinical trial.
Excellent. Well, that leads me actually into my next question. So, and you touched a little bit on this. Some researchers believe oligometastatic disease is curable, and cure is a tough word in terms of metastatic breast cancer, and it's not typically a word used in this context. But what does the research show that suggests that this could be a curable subtype of metastatic breast cancer? I guess, Dr. Shimura, can you kick us off on this based on some of your trial work or any other data?
Yeah, sure. So I think when people use those words, they are really referring to the fact that if we just sort of look at all these single institution, smaller trials, some of which have now 7, 8, 10 years worth of like follow-up data, you see that probably about 1 in 5 patients seem to be alive and at least stable disease, not progressing over a long period of time. So I think we can say that there's about 20% of patients seem to do quite well over very long periods of time. If it's really cure or not, that's a word I would like to not use, but I think a lack of progression and survival over like a decade is quite exciting.
To clarify, you mean about 20% of the trial participants, let's say in the stereotactic trial. So only 20% of patients in your trials for oligometastatic breast cancer have had a 10-year long-term. Interesting.
Yeah.
So even in the SABRE trial, is that the one you're talking about?
No. I'm just talking. I mean, so if we solely focus on the sort of single institution studies, if it's from like Rochester or Chicago or Sloan Kettering, that like have specifically looked at long-term outcomes of a series of patients treated, what we can say is that about 20% seem to have long-term progression-free survival. So sort of no new areas of growth. And and I think that is what drove people to actually want to do the actual real trials, actually want to do actually is the impetus to really do these larger phase 3 trials.
Right. Dr. Tripathy, do you have thoughts on data that you've seen? And I would also like to expand it to more anecdotal. I know that's not something that you always want to share as researchers, anecdotal data, but I have to believe that just from speaking with other patients and the sort of elusive 1 to 2%, of metastatic breast cancer patients that seem to have this very long, I know 1 to 2% is a small number, but it feels like just from speaking to other patients who may not have been in trials or who may have been treated aggressively or not, who are oligometastatic, it feels like there might be a larger number that's just not tracked. That's just from me speaking with other patients. But
yes, you're absolutely right. The whole field started by anecdotal stories of patients who had these very long remissions after having, for example, a resection of a solitary pulmonary metastasis. And we've had these case reports dating back to the 70s and 80s. At MD Anderson, we published our initial series in the late 80s of patients who had these very dramatic responses to chemotherapy, and their tumor would disappear completely, and they'd achieve a complete radiographic remission, which means that you cannot see anything more on x-rays. We call that a complete response. Now, most of these patients, unfortunately, still do have occult microscopic cancer that eventually will grow again. But what we noted that there was a small number of patients that never did progress. They lived the rest of their lives and died of something else. And that's how you define a cure. You can never say someone is cured at any given point in time. But if they live their whole life and die of something else, then we call that a cure. And once we have a lot of data on patients, then we can use statistics to tell patients, look, you have an X% chance of going the rest of your life without having a recurrence. We tell that all the time to patients with early stage breast cancer so they can make decisions about different treatments that would, and by how much it would change that expected outlook. So we do know that some patients do live the rest of their lives without a recurrence. We don't have a good way to monitor for that. And that's going to come up later in today's talk, is are there some newer technologies to monitor that would inform us as to how to treat patients? So we can't just say that people are cured or not at any given point in time. And then finally, part of the reason we need to do large prospective studies is that our observations can be biased. We might selectively remember a case of or a number of patients that recurred and have a distorted sense as to how many patients we can cure by being very aggressive. And only by doing very large studies where a lot of people are contributing a lot of information can we get real life statistics that patients can use. And even that's challenging because it's a rare disease. And there may be a lot of factors that influence things like the receptor subtype, the size of the tumor, the site of the location. These are all variables that will we'll be able to study a little bit better with a large prospective study like the one Steve is running.
That's great. That's a really good point about biases. And I think as patients too, we want to hang on to hope, so we hear of cases of the 30-year survivor, or the very rare 30-year survivor, or the person like the patients that you might be talking about. And we like to ask questions like, what's the longest term, MBC patient you've ever met? So we like to hold on to that, but we also, we like to hear these stories because we're living this disease. So would love to hear your, it's great to speak with doctors and researchers like yourselves. And many of us who have this disease are feel very fortunate to be getting more aggressive treatment if we have oligometastatic disease, and to even know the term. But there are many patients who might have medical teams that don't know the term, don't believe in the term, and are not taking a more aggressive and curative approach. Do you have any advice for those patients who might be doing their research and might be hearing this talk, let's say, but whose medical teams are just not supportive of this type of approach?
Well, I think the important thing for all of us as physicians is to remember that we're all learning. None of us know everything. Yeah. We need to stay informed about the current trends. We need to stay current by the latest through continuing medical education, through attending case conferences, and all the other things physicians do to expand their awareness. Particularly when there's an opportunity to enroll someone on a clinical trial where we're trying to answer a question more definitively, we should take that opportunity. And those of us that run trials try to make our trials as accessible as we can, both by making the eligibility criteria reasonable, but also by widely promoting the trial and making sure that people are aware of it. Awareness is just the most important thing. And then I just want to say one more thing about why it's important for us to start to get a handle on these statistics is we don't want to put patients through life-threatening procedures when the chance of helping them is so small that it's not worth the risk. On the other hand, if you have a relatively safe treatment that has a very low complication rate, then not knowing the projected benefit is a little easier because you're not taking a huge risk, and it's a risk balance issue. And so the development of some of the newer technology like stereotactic body radiation has been great because it is relatively safe. Now there are some complications, but it probably allows a greater number of patients to undergo things as opposed to, say, surgery when that's all we had.
That's great. That's a really good point. Dr. Chamorro, any thoughts on that, on stereotactic body radiation?
No, I mean, I would agree. I think the thing to keep in mind, and that we showed on the initial energy ERO1 trial, is that it was incredibly safe in the short term. So the endpoint of the trial of trying to do a big national trial and treat 3 to 4 areas was if you had any serious complications in the first 6 months. And answer was, it was actually 0, right? So meaning it was very, very safe to do across 100 institutions with good quality assurance in the short term. But as the manuscript is going to show, and this is the great thing about doing these large, well-funded trials, is that the complications do increase over time, so that we have people getting pretty serious complications 5-6 years out. So it's, on the good news is that almost everybody's still alive on the trial, which is good. And it's good that we are following them. But I think that it's, to go back to the point, it's why it's so important to have these statistics on the number of people who we benefit, because we know that patients who present with oligometastatic disease seem to do well and are the ones who are going to live long, likely no matter what we do. So therefore, we have to not only worry about the short-term complications, except think about these long-term complications. So it's why I'm very cautious about doing these types of treatments off of clinical trials.
Interesting. Can you talk a little bit about what types of complications you're seeing in long term?
Yeah, and so
is it the type of location of mets?
Yeah, exactly. I mean, anytime you do high dose radiation therapy, any of the kind of surrounding organs could be injured, so that you could have injury to the like trachea or the breathing tube or to the swallowing tube or the esophagus. All of these things can cause bleeding or could need even like surgical intervention. So again, these are late complications, except they do happen. And since patients who are oligometastatic seem to do well, these are the ones who are likely to live long enough to see these complications, really driving home the point why we need the trials. We need to know what number do we help to then sort of look at the risk benefit ratio.
Interesting. That's really an excellent point. And great to know that they're living long. And you're right. I think across, whether it's radiation or systemic treatment, knowing what the long-term and scanning, right? Ongoing
Yes.
imaging, what are the long-term risks and benefits? Great. Can you talk a little bit? I think you both have alluded to some of the newer technologies, the predictive and prognostic biomarkers, and some of the newer things that are coming out to potentially, detect which patients are oligometastatic or detect who's going to recur. Can you talk a little bit about, I'm not sure who would like to start, but would love to hear some of the newer things that are coming out. Dr.
I think
Tripathy?
that's a multifaceted answer. First of all, there's just imaging technology, what we've been using
Okay.
for a long time. Our imaging technology is better. We're starting to get some functional information with things like PET scans. And just very recently, we now have estradiol PET scans. This is an estrogen molecule that is bound to a tracer, so we can specifically look at that in response to endocrine therapy.
I'm sorry, can you talk a little bit more about that? So is that a different type of, instead of a traditional PET scan, hormone positive breast cancer patients would have that type of?
Yes.
Interesting.
Well, it's a very subtlety. I don't want to spend too much time on it. The standard PET scan is based on fluorodeoxyglucose. This is a form of glucose that is utilized to a much greater extent by cancer cells than normal cells, and that's what allows PET scans to work. But you can also label this radioactive material with other compounds such as estrogen itself, and estrogen binds to the estrogen receptor, so you can directly look at that as well. And we're just starting to learn that technology. I just was using it as an example, but the other emerging area that's very exciting is being able to detect very small amounts of tumor in the blood, even in patients who may not have any radiographic findings. In fact, we're finding that in early stage breast cancer, we may even be able to predict who's going to recur before we see anything on the scans. That technology obviously isn't reliable enough yet for us to be using in the clinic, but it's being developed further. And it'll never be perfect. There will always be some people that are missed or some people that are falsely positive. So that's a concern too. So all the tests have these false positives and false negatives that we have to worry about. But tumor DNA is shed in the bloodstream, even in people that may have microscopic disease sometimes. And we now have better ways to measure this. Circulating tumor DNA or circulating tumor cells themselves are both factors that when someone has them, it does predict that they're going to either recur or progress more sooner. So it's something that we can now embed into these trials to help guide patients as to how to select patients, how to monitor them, how to know when other treatment might be needed. For now, we're just going to be measuring it and then correlating it.
Okay, great. So that's still in trial mode, but ultimately that'll be something that potentially could be used.
That's correct.
Ongoing. Any thoughts, Dr. Chamorro, on this topic?
Both the circulating tumor cells and the circulating DNA, they are actually embedded endpoints in the energy BRO2 ongoing trial. So it is actually quite exciting that we should be able to say, well, could we maybe better select patients to undergo these types of aggressive treatments if, say, one starts out with very low numbers of circulating tumor cells or circulating DNA, and the power of these big trials then is that you'll have a large number of patients to really make these comparisons and to even compare the technologies.
That's fascinating. So are you saying that you might have, let's say, two patients that have two small mets, but one might have
a high number,
higher...
right, exactly. And so basically our actual hypothesis in the trial is that the patients who have, say, 0 or 1 circulating tumor cell per like vial of blood are the ones who are going to actually derive the most benefit from aggressive treatment. So like, this is a hypothesis, but at least we should have the number of patients and samples needed to really evaluate that.
How interesting. That's amazing. So let's move on to talking about treatments. What is your position, Dr. Tripathy, on surgical removal of a patient's initial tumor when they're oligometastatic? And if you don't suggest removing it on initial diagnosis, what are the benefits or risks of removing it later on? I know this is a controversy at times with whether mastectomy is worth it across metastatic breast cancer, but what are your thoughts for OMBC?
Yes, if a patient is presenting with newly diagnosed breast cancer, and then as they go through their staging, we find a single or maybe 2 metastases that could be either surgically removed or potentially radiated or treated in some other way, we do consider them as someone that we may treat with curative intent. And that's the term we use, curative intent. So that means that we are also going to treat their early stage breast cancer in a way that would be curative. Because sometimes we don't even do surgery on patients who have a new breast cancer, but already have metastases. We don't even do surgery on the breast. We go ahead and treat them medically because there have been studies showing that surgery doesn't really help, although there's still some controversy. And we still may do surgery in patients that we think are going to benefit in other ways. For example, it may make the lump less bothersome or painful, or if we're concerned that that area could grow and grow through the skin or something like that, and we want to prevent it, we'll still do surgery. But what we do for the metastases at our center is we may not treat the metastases itself right away. We may put the patient on the best systemic therapy that we think they need. Because even if we were to go and take that out, we still want to use systemic therapy for the microscopic cancer we can't see. We want to make sure that this isn't a patient who in the very near future is going to be developing other metastases that we can now see, so that the whole attempt to do surgery would have been something futile because they already had these metastases that were on their way to growing up, especially if they happen to be really resistant to some of the therapies we use. So we start them on the best systemic therapy. And then over time, if the follow-up scans don't show any new areas, then we may go ahead and either enroll them on a trial or ideally, that's what we always want to do for eligible patients, or we go ahead and treat that oligosite or sites. So we give it some time to declare itself. And how long do you wait? What drugs do you use? All of that is still up in the air. We use the best systemic drugs that we think. For example, someone with hormone receptor positive cancer, we would probably use the best metastatic treatment, which currently is a hormonal therapy like an aromatase inhibitor or Faslodex, right, along with a cyclin-dependent kinase inhibitor, which I know is one of the questions right that you would ask. That's what I would use in someone with that type of a cancer.
Yes. Actually, yeah, that is one of my, oh, go ahead. Sorry, go ahead.
Oh, no. And then I will add that it is the exact same approach as like he described is how the phase 3 trial is currently being run. So you basically treat the cancer, you actually start the systemic therapy, and kind of going back to something like which was alluded earlier, we actually strongly recommend at least a few cycles of systemic therapy to really be sure that patients are not progressing, right? So it is kind of comforting to hear that that the approaches off trial and like on trial are virtually identical.
Interesting. So you want to see that they're truly oligometastatic, you're saying?
Right, exactly. I think because the fact that our sort of imaging can only pick up a certain size, and, you know, any argument is always, well, if you see one spot, you could have 10 spots. So, so actually, like, we strongly recommend like 3 to 9 months of like systemic therapy before actually doing either surgery or the stereotactic body radiation.
Interesting. Oh, even before surgery. Interesting. And on systemic therapy, I know I personally, when I was at MD Anderson and being treated by Dr. Eric Strom before I was with Dr. Tripathy, they had suggested chemotherapy, and that was before all the, CDK4/6 inhibitors were in play. But right now, Dr. Tripathy so for hormone positive breast cancer, is chemotherapy or, hormone therapy recommended for the initial therapy for someone who's oligo?
So let me clarify. I mentioned initially that I would want to treat the patient with the best treatment we have for metastatic disease, follow them, and then if we decide to treat them for oligometastatic disease, now we kick into curative mode. And if we're in a curative mode with someone with early stage breast cancer, for hormone receptor positive cancer, sometimes that involves chemotherapy followed by hormonal therapy. So now we go back into that mode because now we're going to overlay surgery and even radiation therapy if that is the best approach that we would use for someone who's curative. Now, this is someone who's presenting with breast cancer in the breast as well as a metastasis, because if we're going to be treating them in an oligometastatic, potentially curative mode, we have to treat the breast cancer itself the way we would treat someone for cure with early stage breast cancer, which is going to involve surgery, the appropriate medical therapy, and radiation. However, the treatment for metastatic hormone receptor positive breast cancer and early stage hormone receptor positive breast cancer is actually different. We do use chemotherapy in, for example, node positive hormone receptor positive breast cancer. We typically use chemotherapy as part of it. So now we would switch back into that mode, but we may not necessarily need to expose all those patients to chemotherapy at the very beginning. Now, some physicians will do it a little bit differently. They'll say, we're going to go into curative intent mode right away. That's generally not our approach because we think that we're going to be over-treating some patients who maybe didn't need it at that point in time. If they were going to be developing spread during that observation time, we would just use the best endocrine/biotherapy.
Interesting. I can see why this is so challenging. So many different scenarios to consider. Back to just on treatments, sort of, patients that are living longer. There are some patients who are doing well on monotherapy. And again, we're talking about hormone therapy. I apologize, but there are a lot of women in our, Facebook groups who are oligometastatic Facebook groups who are doing really well on a monotherapy, like an aromatase inhibitor, a Kisqali or letrozole. No, not Kisqali. Sorry, but a letrozole or Arimidex. How do you feel, Dr. Tripathy, about remaining on just a monotherapy versus adding an additional therapy to that, such as a CDK inhibitor?
I think that's a very difficult question. I tend to think of someone who's in an oligometastatic setting as being sort of in between those two worlds. At the very initial point, I would actually use the best treatment. So I would use a CDK inhibitor for some period of time. However, let's say this patient has oligometastatic disease, so you're treating them locally and you're giving them endocrine therapy and CDK inhibitor therapy. And if they had early stage breast cancer, they may have even gotten chemotherapy. And now time goes on, and let's say you're 5 years out and the patient has not had any signs of recurrence. They're still on a CDK inhibitor. They're having side effects from the CDK inhibitor. At this point in time, it's very difficult to know how much benefit they're getting. Now, typically, anyone who ever had metastatic breast cancer and they're on endocrine therapy and a CDK inhibitor, the standard of care is to leave them on that therapy until they progress or until they develop side effects that require them to come off. So, but oligo is different, right? So at some point when you go 5 or even 10 years, you have to ask yourself, gosh, do I peel away the CDK inhibitor and now just use endocrine therapy? We don't know the answer to that question. But the standard is to use the best. They're still technically stage 4. This patient's stage is still stage 4. stage 4 NED, and no evidence of disease. That's the term we use. And, but we don't know really, it's a small group of patients, so we don't know how long they need to be on the maximal treatment.
Right. Same question, I guess, Dr. Tripathy, with imaging. And I guess I would love to hear from both of you on this. For ongoing imaging, since Dr. Chmura, you're a radiologist, for patients who, I would love to hear from you about patients who are sort of in their initial years of being oligometastatic, let's say in years 1 through 3, versus patients who are in this long-term, hopefully long-term, no evidence of disease and are oligometastatic. What would you recommend in terms of imaging and scanning to monitor their disease? And of course, hopefully we'll have these, circulating tumor counts and other types of other ways of tracking their disease. But for now, what would you recommend? Type of scanning and frequency of scanning? Dr. Tripathy, let's start with you.
Okay, so I don't think there is a defined schedule. I tend to scan my patients with metastatic breast cancer every 2 months if they have very newly diagnosed disease that's aggressive and they're on treatment. But typically I do it less frequently than that, maybe every 3 to 4 months. As time goes on and they haven't developed progressions, I may spread that out a little bit more, because that's telling me about the chronicity or the slow grade nature of their cancer. And even though I can't exclude that they may still not recur, they may still have microscopic cancer, I just know that they've gone a long time at this point and they probably have more indolent disease. So I might spread it out to every 6 months. And then I probably just keep it at every 6 months in terms of scanning them. But then let's say someone now is out to 10 years, I might even consider dialing it back some more at that point.
Great. Dr. Chmura?
And again, that is exactly how the clinical trial is designed. It is going to be a CT scan every 3 months for 2 years. And then after that, we actually recommend every 4 to 6 months.
Every 4 to 6. So 6 months sounds like it's the top. I mean, you would never go annual. Is that true for both of you?
I wouldn't feel comfortable.
Yeah, I think annual is something I might reserve for that very rare patient who is just so far out that, 10 years. But I think it's better to, because, if a patient has a very isolated single site recurrence 5 years out, that might not be a unreasonable patient in which to then again do oligometastatic treatment. So now they're back in the same consideration for that. Right. And so, that's why we monitor, is not only
to catch it early,
something about it.
Right. That makes sense. Great. So let's move on to research a little bit. We have just a few minutes left. There are so many research questions, and many of us patients would like to get more involved. Some research suggests that up to 20% or 1/5 of MBC patients may be oligometastatic, but data is very sparse. What do you think needs to be done to better understand oligometastatic disease, and what do we need to do to get better data? I know both of you have talked quite a bit about the needs that we have. Dr. Chmura, let's start with you.
Yeah, I mean, I just want to keep on saying, and I sound like this broken record, but we need to accrue to the phase 3 clinical trials, right? There is the Energy BRO2 trial, which is open in the US. It has actually successfully accrued the phase 2 part. It is on pause to actually see the signal to then see, is it going to continue to move on to the phase 3 part. We have already accrued a 129 patients on that. There is the European trial, which is almost identical. It's called StereoSign, SEIN, and that's about halfway accrued. Also, I think that they're at about patient 150 out of their 300. So again, I just think that we have to encourage patients to really go on trials, and I think both patients and the physicians have to put our biases at the door and just put patients on the trials.
Mm. Well,
Yes, I think that in general, research is the way forward. It's really great that we have well-designed oligometastatic trials, particularly Steve's trial, which is a national trial that's accruing well and is already generating some data. And I really want to devote the rest of the time to Steve's comments about how the trial is going, because I do think it's a national priority for us to get this done.
That's wonderful. Yeah, it's exciting that so many are moving into phase 3. Dr. Chamor, would you like to speak a little bit more?
Yeah. So
about some of the results.
I think the interesting part about the Energy BR02 trial is that it's a phase 2/3 design, meaning that it is designed to look for a early signal after the first 129 patients that are randomized. The patients are being stratified by hormone like receptor status, by like triple negative status, by HER2 status, all trying to really do a quality job in terms of being able to assess outcomes. And so after the phase 2 part as accrued, which is now, it goes on pause. And the idea of that is to say await the events or having people fail, and then after you have enough to then unblind it to see, is it about twice as many people failing in the non-SBRT or surgery arm? And like, if it is, then it's going to continue to enroll to the phase 3 portion, which is looking at overall survival at 5 years. So I think the only real data we have, which I think is quite exciting, is that we accrued patient 129 October 2019. We had predicted from our modeling of sort of first line metastatic breast cancer patients going on other clinical trials that we should have the number of events or the number of failures in just 6 months. And that should have been then spring of 2020. Well, it's now spring of 2021, and we still don't have the number of events. And in fact, we now predict it could be Christmas time of 2021 until we do. So it means that all the patients going on these trials are doing well. And I think this is really exciting for all of the patients and for the research, because at least it shows us that how we at least define oligometastatic disease is a true clinical entity, that these patients are doing significantly better than we would have predicted.
That's very exciting. Do you feel like, given the size of this trial and where the data is at, that the results might potentially lead to having some standard guidelines for oligometastatic disease?
I don't really know. I mean, I don't know what it's going to show, right? I mean, it could just show that the two arms are doing about the same. I don't know. So I think I'm going to hold off on that. I think I'm just excited because I feel like at this point I can finally say that that at least the definition of de novo oligometastatic disease is a good one. It means that patients going on these trials do well, and this is a good population to study. So I think I'm going to hold my excitement at that, which I think is pretty exciting.
Yeah, definitely. That is exciting. There seems to be, as you're talking about all this data from research, you have all this clinical trial data, but there's so many oligometastatic patients like myself who are self-identified, through social media and other channels, and we're so willing to share our data and help advance research. Is there anything we can do beyond participation in clinical trials to help support this research for oligometastasis?
Yes, I think it's very important for patient advocates and others who want to see this field move forward to advocate for research. Number one, help with public outreach so people know of what trials are available. Number two, when it comes to funding for new research, to support your legislators that know the importance of research. You know, you mentioned how are we going to use this data? Well, the reason we do these trials is to better inform our patients to make better decisions. Nothing's ever perfect. There's always some uncertainty in the recommendations we make, but we want to make recommendations that are evidence-based, where we have some statistical basis for a patient to make an educated decision about the harms of treatment balanced against the potential benefits. In this case, the potential for a long-term remission or a long-term cure. It could be that patients that undergo treatment may not be cured, but they may live a lot longer without their disease recurring, and they may have a better quality of life. We don't know. I mean, that's why we do these studies, so we can counsel patients. It's never going to be perfect. The clinical trial process is an ongoing issue. The minute we finish one trial, there's a bunch of other questions we need to ask, and then we move into the next one to refine our approaches. So I think being informed, being active in terms of informationally and voting and making your voice heard as a citizen. These are all really important parts of patient advocacy. And I just want to take this opportunity to thank you all, LLBC and Elpida, yourself and Sharon and Amy and all the others for being a part of this process. And everybody who's listening, we have to be engaged and involved for our own goods.
Yes, absolutely.
Well said.
Yes.
Well said. Thank you so much, Dr. Tripathy and Dr. Chmura, for joining us today for this amazing conversation. I've learned so much.